Hello, good evening, Dr. Sara.
Hello. Hi, how are you?
I'm good. How are you?
Alhamdulillah, I'm good.
I'm just looking at the list. Um,
Okay, we can wait if you want. No problem.
I think we have still. Yeah,
Yeah,
okay. The number is increasing, but also don't want to delay you.
that's
So,
okay. If you want us to wait for like a couple of minutes, no problem.
okay, so let's give it 2 more minutes.
Yeah,
Thanks.
most welcome.
All right, I think we can go ahead.
Oh,
Good evening, doctors, and welcome, Dr. Sara. Uh, we reached our last session with with you, and I mean, I really appreciate what you're doing for us.
and I appreciate the attendance and the attentive listening and the participation and for the invitation.
رؤية رؤية.
Okay, doctors, please try to mute your microphones. And welcome, Dr. Sara. As you all remember now, Dr. Sara is a family medicine specialist. And please, Dr. The space is yours.
Okay, thank you, Alex. So, Assalamu alaikum. يعطيكم العافية جميعا and happy to be with you today and today is our last session. I hope inshallah you have got the best of what we have passed or what we have finished by now and inshallah you will get like benefit from our session today. I'm really pleased to answer any of your questions at any time. You can just contact me by WhatsApp and I can answer all your questions. And I wish you and I hope that you will do very, very good in your exam and do great even in your exams. And I wish you all the best. So let's start our session today. So today we will talk about other emergencies that we didn't mention or we didn't cover in our previous sessions. They are not under a specific system, so that's why we will cover it today separately. Like it's a miscellaneous groups of emergencies that we may come encounter in primary care. They are maybe not so common, but they are not uncommon. We may face it, so it's good to know how to manage similar cases. So uh, the things that we may cover today are animal bites, burns, RTA trauma, whether head trauma or other types of trauma, acute abdomen and neurological emergencies, corneal abrasion or red eye in general, and ingestion of medications, corrosives in pediatrics specifically. So we will start with a scenario. I will read it for you this time. A 12-year-old boy presented with his father due to a street dog bite on the right leg. The bite was not bleeding. Vital signs were all normal. So I need one of you, please, to tell me how you are going to approach this patient.
Can I?
Yes, please.
Mm, Doctor, I will assess the site as it on the right leg.
Mhm,
I will see the depth of the wound,
mhm.
whether it is infected or not,
Okay.
or the bite has broken the skin because there is no bleeding, but I am not sure about the abrasion or any scratches.
Mhm.
And I will further see is there any foreign body in the wound, or I can, as it is not bleeding wound, I might squeeze the wound to bleed it, because sometimes the rabid dog, the saliva is more infected, and then I will inform the sister to clean the wound with the normal saline.
Excellent. Yes.
And then I might ask his father also regarding the vaccination history, either because he's 12 years old, yeah, and I need to check either he took the booster at the age of 10 to 12 at school,
Yeah.
or did he missed it? And if he missed, so he should take the tetanus toxide in the clinic.
Okay, very good.
But
Anything
not
else? Yeah.
biotic, doctor. Should I give or not? Because it's superficial wound. I'm not sure about it.
What
And
is it? Antibiotics, you mean?
biotics, yes.
Okay, we will discuss this. Okay, so
Okay.
you are sure in this scenario whether you will give the antibiotics or not? Okay, we will
Yes.
see the indicators for for antibiotics. Okay, what else? Anything else you want to do?
Yeah, I will refer for the preventive care,
Mhm.
because it's a street dog as per the scenario. So, so I will send for the preventive care opinion.
Excellent. Thank you very much, Dr. Simon. I think Dr. Simon covered it all. Okay, but we will discuss few points that will make us more comfortable in dealing with such situation. So when we talk about animal bites in general, there are like animal bites that are very common. Especially we are seeing it a lot in the clinic. Sometimes we are seeing a lot of dog bites, cat bites now. They are very common since most of people they are having like pets at home, or there are a lot of also animals like in the street, like dogs. Previously, we were not seeing a lot of dogs in the street, but now we are seeing sometimes dogs in the street. A lot of cats, maybe like a child or somebody was trying to play with a cat and suddenly this person got a bite. I have seen one patient once, he was about to help a cat where he found her on a bridge. So he felt that the cat is like, this cat doesn't know what to do. So he was trying to help her and put her on the ground, where suddenly she bites this gentleman. So he came to us with a bite of a cat. So it's good to know how to deal with those types of bites. Also, a human bite is one of the things that we may come encounter. And I have seen a patient, a male patient, who presented to me with a bite of like another person by a fight. Also, there are like squirrels, rodents, and rabbits bites that we will like talk about in brief. So regarding dog bites, puncture would from the canine of the teeth, which anchor the victim, while the other teeth bites shear and tear the tissue, causing stretch laceration. So what we are expecting to see, it's a shear and tear and laceration from the canine's teeth. So the canine teeth will be anchored, and the other teeth will be like getting inside the skin. The risk of infection is 2 to 30%. Most common animal bite is the dog bite, or most common mammalian bite is the dog bite. It accounts for 60 to 90% of all bites. Regarding cat bites, as you can see, the risk of infection is higher with cat bites, but it is less common than dogs bites. The thing is that the teeth of the cat are fine and sharp, so they are sharp teeth, but they are very fine. Weaker bite than dog, but capable of penetrating bone and joint capsules because they are sharp and like a little bit long, and they can like go deep. So that's why they may reach up to the bone or the joint capsule. So especially if they are around the joint. So a cat bite, the cat, maybe it looks very like poor and nice, but the cat's bite is not nice at all, and it has a higher risk of infection. So just consider this and keep it in your mind. Human bites also can happen. Occlusal injury inflicted by actual bite, or clenched fist injury. Clenched fist hits a person's teeth, and the bite will develop after like giving a pinch. Often during a fight, usually it happens, causing small wound over the metacarpopharyngeal joints. Okay, I'm sure that you can imagine. So the risk of infection in a human bite is 9 to 50%, which is not a low percentage. It is a little bit high, up to 50%, and but it is not very common. It accounts for 4 to 23% of all mammalian bites. Okay. So what are the complications of bites that we should keep in mind? Of course, wound infection is the most common one. Septicemia, like in severe cases where septicemia may develop, or septic arthritis, especially if the bites developed around the joint. Tenosynovitis may develop. Tetanus, of course, and rabies may be also due to the bite. So tetanus and rabies should be considered in any human or mammalian, dogs, cats, or any animal bites. High risk of infection. So who are the people that are high risk of getting infection from a bite? Diabetic patients, patients who with no spleen, or they are having cirrhosis, immunocompromised patients, patients under radiotherapy, or if the wound is on the hand. So if the wound is on the hand, there is a high risk of infection. So whenever we are encountering a patient with a bite, whether an animal bite, a human bite, we have to assess the bite itself, how it happened, where exactly the location, what was the like a creature, or what was the animal, or what was the like the cause for the bite, who did it, if it was like a human bite, because, and who it means, like if it was a human, if she's a male or female, it's a relative or not relative. Do you know that this person has like diseases, any like infectious diseases, or who will make us think of if there's any like type of abuse, or if there was any fight? Do we need to encounter medical legal issues? We should encounter a police or something. So all of these will be answered by who did the bite, when it was, which may also affect our management, especially regarding the tetanus and the rabies vaccinations. If there is any broken skin, as Dr. Saima said, any risk factors for infection, the risk factors that have been mentioned, immunocompromised, radiotherapy, diabetic on the hand, or asplenia, or cirrhotic patients. Tetanus status, as Dr. Saima also mentioned, is it within the last 5 years or more than that? If it was happening to a child, does this child took the booster dose or not? So the general management in case of bites, we have to assess the ABCD. Of course, if it was like a very severe bite where the patient was bleeding and he's like semi-conscious or unconscious, we may like start with the ABCDE to make sure that the circulation is intact, or do we need to give like IV fluids? This in severe cases. For example, sometimes a rabid a dog will attack a human being and like have multiple bites, where the patient may present with shock. So we have to consider this and keep it in mind, and know how to deal with it. Examine the bite itself by the bite assessment that we have mentioned. Remove any foreign body like teeth from the wound if it is available. Encourage the wound to bleed by squeezing and trying to let the wound to bleed, as Dr. Saima also mentioned. Irrigate with warm running water. So it's not only cleaning, it's like irrigation with normal saline, like keeping the normal saline move on this wound to make sure it is clean, or as much as possible. We may consider giving analgesia, especially if the patient is in pain, and usually if it's a severe one, the patient will be in pain. We may consider paracetamol or ibuprofen, or NSAIDs, non-steroidal anti-inflammatory. Antibiotics should be considered, and we will discuss now when it should be considered and what type of antibiotic we will give. Tetanus toxoid and rabies vaccine, and we will also mention those in a while. So decision for antibiotics. Oral antibiotics will be given for all animal bites on the hand, foot, face, and genital area. So those are areas where infection is high, or the risk of infection is high. We have mentioned hand in the previous slide, but if it is also in the foot, face, and the genital area, since those areas are like critical areas, in this situation, it is better to consider the antibiotics. So hand, foot, face, and genital area. Don't forget those 4 places or 4 areas. puncture wound involving joints, tendons, ligaments, a suspected fracture. So all of these will should assure us to, or encourage us to start antibiotics. People at high risk of infection, the ones that we have mentioned, people with prosthetic valves or joints, it's better to give antibiotics, especially if the bite is around or like just beside the area of the prosthetic valve or the joint, or the prosthetic joint, or the replaced joint. So a 7-day course of co-amoxiclav or augmentin is preferred. Metronidazole, flagyl, or clindamycin, which is covering aerobic activity, with one of the following. So it's either amoxicillin, co-amoxiclav, which is the augmentin, or metronidazole or clindamycin with one of the following: doxycycline, trimethoprim, penicillin, ceforaxime, ciprofloxacin, or levofloxacin. So all of these are possible options that can be given. So it's a metronidazole with one of these, or clindamycin with one of these, or augmentin alone. So when to give tetanus to all patients except if it was being given within the last 5 years. Rabies immunization. If this animal was a healthy cat or dog, which is like it's in your house, you know that, or in their house, in the patient's house, they know that it's clean, it's fine, it has no diseases. This animal was being tested, he has vaccinated. All of these the patient was sure of that. There will be, ideally, according to the guidelines, a 10 days quarantine of the animal itself is recommended. If any symptoms on the animal appeared, then vaccination is recommended for this person and the one with the bite. If it is a rapid animal, like in the street or something, and it was aggressive and had immediate vaccination should be given. If it is unknown, we don't know, even if it was at home, but we don't know if it is vaccinated, or if this animal is vaccinated or not, or it is a street, but we don't, it's a street, but it's not rabid. And this, we have to consult the preventive medicine. So in general, an animal bite, like the dogs and cats at home, and we are 100% sure that the animal is fine, has no problem, we can wait for 10 days of quarantining the animal itself, not the person who was getting the bite, the animal. So 10 days of quarantine of the animal. If any symptoms appeared on the animal, then we have to take the vaccine. If it is a rapid animal, then right away we'll take the vaccine. If it is unknown, it's better to consult the preventive medicine. Let's talk about real life. In real life, even if it was a house cat or dog, some doctors prefer to refer for preventive medicine, and some of the preventive medicine doctors prefer to give the anti-rabies vaccination. So it is safest for the patient, to give the information, to explain to the patient. Maybe we can counsel the patient about this issue, and the patient may take a decision, or we may encourage just seeing the preventive medicine, and then the preventive medicine doctor will participate in the decision making. But those are the guidelines that they are saying this. So when we have to refer a bite or a patient with a bite to secondary care, which is usually will be to surgical site, if there is penetrating wound that needs dressing, proper dressing, cleaning, healing, maybe suturing. If there is a facial wound, except if very minor, if there is bite with a foreign body, if surgical intervention is needed, like in debridement or reconstruction. If severity is difficult to assess, we don't know, we cannot assess properly the bite, so it's better to refer this patient for secondary care, surgical intervention or surgical opinion. So this is regarding bites. If you have any question regarding the bite, you can write it down and we can discuss it at the end of the session. So we will talk about another scenario. Also, I will read it, then somebody will help me in discussing this case. So it's a 5-year-old girl brought by her mother, who rushed into the clinic carrying her child. She had a burn on her left hand by the iron machine at home. The child was crying and in pain. On examination, the left eye had an erythema with a blister measuring 3 by 5 centimeters. Not the eye. It's not the eye. The left hand. Sorry, not the eye. Okay. So the left hand had an erythema with a blister measuring 3 to 5 centimeters. So who wants to participate in this scenario?
ممكن دكتورة بعد
أكيد تفضل.
اتفضل يا دكتور خلاص مفيش مشكلة. اتفضل.
لا والله يا دكتورة، لا والله من بعدك، لا والله تفضل.
الحالة الجاية حق الدكتور إن شاء الله. خلاص دكتورة تفضلي.
اوكي.
ما زعلكم تاخذون حالة.
Yes. Okay. And first of all, we will take. It's better to take the child to our emergency room, because the burn situation sometimes it's a scary and anxious mother. It's better to be in emergency room. We will evaluate the child about ABCD and DE. We should see the site of the burn, the degree of the burn, the type of the burn. Yani as in this case, this is first degree burn with blister on hands.
How can you like differentiate if it's now you are not seeing the burn, but you are like the explanation of the burn is erythema with blister. So which degree of burn you think is this?
This is a superficial burn, first degree burn.
Mm-hmm.
Okay.
Mm-hmm.
Yeah, and يعني it's considered type 1.
Okay.
And this is only a small area, 3 3 في 5. It's okay, and it's a type of burn. It's by air. It's not chemical or electrical burn or inhalational burn that needs more cautious with management. Otherwise, we will start to ask the sister to irrigate the burn with cold water. We can give the baby child analgesic like paracetamol or Profen as he's crying. It's paining issue. Otherwise, it's better to keep the blister intact. Don't touch it. And we can apply flamazine gauze with flamazine dressing with Vaseline gauze, non-adherent gauze, and follow up the patient later. Yeah.
Very good, very good. Thank you very much, دكتورة. أنا بس عندي one comment about the degree of burn. Whenever there's a blister, it's a second degree superficial.
Second degree superficial.
هم مو عندنا first degree، بعدين second degree في two types، صح؟ Superficial و deep.
أيوة.
With a blister, erythema blister. Whenever you see a blister, then it is second degree superficial. Okay.
Okay. Thank you.
Thank you. Okay. So when we talk about burn, or any burn anywhere in the body, we have to look for the degree of the burn, the type of the burn, the severity of the burn. We may use the rule of 9 that we will mention in a while. Of course, we have to assess the patient as ABCDE, as Dr. mentioned. We have to do examination, specifically neurological examination, to make sure that the pain, especially if the burn is severe or like it's a deeper type of burn. So we will have to make sure that the nerves are intact and not affected. So a neurological examination may be helpful. Medications should be considered, such as painkillers, antibiotics, tetanus toxoids, or IV fluids. Special situations that we have to keep in mind that they are at higher risk of infection of the burn, or like more severe, like deterioration or slowing of healing of the burn, like in diabetic patients, or if it was for first degree on the genitalia, face, and joints. So البايت احنا قلنا genitalia, face, hand and foot. الburn, if it is in the genitalia, face, or around the joints or in the joints, so we have to think of like it's a little bit a red flag, even if it was a first degree burn. So this is a slide showing like a summary of the burns and how we are going to assess them. So we have to check the airway, breathing, circulation. Disability exposure is very important here in the burns because we want to see the extent of the burn. How big is the burn? Like it's reaching where exactly? If there is any like loss of hair, if there is any like skin peeling or any abnormality, we have to see it and assess it properly by proper exposure. So we have to expose the body to look for the burn, but keep in mind that we don't want like to, as we are mentioning previously, keep in mind the dignity of the patient, that nobody is like, everyone is looking and the patient is not being covered properly while you are assessing and doing exposure. Of course, if they are doing exposure, there will be no covering, but at least the dignity will be preserved for the patient. So then we will assess the affected area by the rule of 9. Can somebody tell me what is the rule of 9? Do you know how it is assessed or how can we use it? I'm sure, I don't know if you have used it before in the primary care settings. I haven't seen any like very severe widespread burn in the primary care, but I have seen like a few areas of burn here and there. I have seen one child with lower limb burn bilaterally by scald by boiled water. He came to us like the second attack. I was in a khafara and in the on-call, and he came second time to do dressing. I didn't feel well. I felt like I didn't feel that the child is well. Although he was like a little bit conscious, he was like playful a little bit with his mother. She was carrying him, and all his leg was rubbed with a dressing up to the knee. So I told the nurse, I told the mother, just go and open the dressing and I will come and see it. She came for dressing only. So when I went to see the child, it was a disaster. It was a very bad burn. Maybe, I don't know, maybe it was a 2nd degree, a deep burn. It was like the skin was peeling everywhere, and it was ugly. يعني مسكين, the child was, I don't know how was, the child is like, he was tolerating all this pain and all. Maybe there was no pain, maybe it was a 3rd degree, I don't know. So I transferred this patient right away to the emergency room, and I fortunately saw the patient again in the clinic. She told me, I referred her to Batin, by the way, although they don't have an emergency, and I will tell you where you will refer. I referred her to Batin because I didn't know what to do at that time. I was a resident a few years ago. Fortunately, they saw the child. They did very proper, nice dressing there. It's a very special type of dressing, and they followed the patient up there in the Batin clinic, in Batin Hospital for burns. So please just have a proper look at the burn, assess it properly, try to see it like in the follow-up, because you don't know how it's going, especially if there are blisters, if there was like a peeling of the skin, there was any abnormality. It's something that's not reassuring. It's not only erythema. Please have a look at it whenever you are doing dressing. So let's go back to the rule of 9. Somebody can explain how it is used. You can see here the photo. أحد يعرف؟
هي تقريبا دكتور الابر ليمز 9 واللور ليمز 18. طبعا
شنو ال9 هذا الدكتور؟ شنو ال9 exactly؟
ال9 هي نسبة البيرن، يعني هل نفترض مثلا إذا كانت كل الأبر ليم بيرن هي 9 مثلا، نفترض يعني طرف واحد اليمين مثلا. نفترض مثلا اليد اليمنى من الشولدر للهاند، يعني مثلا كلها هي 9.
تمام.
اوكي، فاحنا بس هي الارقام هي عشان نقدر نحسب معادله باركلاند.
تمام، ممتاز.
ايش الفلويدز اللي بيحتاجها يعني.
exactly.
بس اذا نص الايد يبقى 4.5، نص الابر ليم 4.5 يعني هيك.
So it is the surface area that is covered by the burn، صح؟ مش كثر مقدار السيرفيس اريا بالبرسنتج اللي covered by، صح؟ تمام، عشان نحسب شيء اسمه الباركلاند formula, which is to tell us how much fluid this patient needs and over how many hours. تمام؟
Yes.
So the calculation is 4 ml times the body surface area in percentage times the weight. تمام؟ So الرقم اللي راح يطلع لنا هذه, we will give half of the solution for the first 8 hours and then give the other half on the next 16 hours. هذا usually إحنا we will not do it. إحنا أهم شيء عندنا لما المريض يجينا burn that is severe and we think this patient needs to have replacement by IV fluids, we should start the IV fluids. If we can calculate it well and good, if we cannot just start IV fluid fast, يعني give it as soon as possible and refer the patient to the emergency room where they will manage accordingly. احنا وين نحول عادة؟ ما راح نحول حق الباطين نفس ما أنا سويت لما كنت resident وحولت المريض حق الباطين، although أنا كنت محولته for the dressing not for any other things والحمد لله مشت الأمور وما أعتقد كانوا يعني ممكن يردونه لأن it was very severe. بس you usually have to refer for secondary care for general hospital. In the general hospital they will do their initial assessment there. They will start IV fluids according to the calculation and then they will see if the patient needs to go home or this patient needs to be referred to the specialized center for burns in Al-Batin in Sabah hospital. Okay, so we have to call if there's the pain after we assess the pain. It's not a first degree. It is a partial thickness or full thickness burn. Then we have to call ambulance and refer to the burn center. Or again, إحنا هذا بالجنرال يقولون burn center بس إحنا الburn center مالنا راح يعتبر الجنرال hospital. So a partial thickness more than 10% of the total body surface area. هذيل الناس اللي will be referred. Burn in the face, hands, genitalia, perineum or major joints. A third degree burn in any age group. Electrical, chemical and inhalation burns should be referred also. Burns associated with trauma like a fracture, for example, also should be referred. So the management for us in the clinic, we have to irrigate with running cool water. If this patient is an adult with more than 15% of the total body surface area, we have to require IV fluids by Barkland formula or by just giving like fast IV fluid, but ideally by the Barkland formula. Leave the blister intact to decrease the risk of infection, as the doctors mentioned. Dressing with non-adhesive gauze padding. Tetanus toxoid if it was not taken within the last 5 years. Analgesia should be considered like paracetamol or a non-steroidal anti-inflammatory. We have to examine the dressing after 48 hours. So if it is like a first degree or second degree, like a superficial one, we have to assess the patient after 48 hours. Again, expose the area, examine properly and see what is going on, especially if it is second and third degree. Third degree, we will not just, I don't think we will deal with the third degree, especially at the beginning. Maybe later on they will continue the dressing with us. But if so, and it has been like 48 hours past, it's better to look at the burn again. Change dressing for the second degree burn after 3 to 5 days in absence of infection. Okay. Okay. So this is regarding burns. So in general, يعني في الburn أهم شيء عندنا assess it properly, assess the degree of the burn, consider analgesia, antibiotics, and assess if the patient needs referral or he can manage at home and doing dressing in the clinic. So scenario number 3, a 70-year-old man presented after a fall on the floor due to tripping by a carpet. His head hits the table and a small 1 centimeter superficial scar was above the right eyelid. So it was above the right eyelid. Blood pressure was 130/70. His heart rate was 80 and neurological examination was normal. So anyone please can help me with the scenario or with this patient, let's see.
دكتورة.
يلا دكتور تفضل حياك الله.
هو اللي هي superficial scar ولا superficial wound يعني؟
إيه superficial wound. Yes.
superficial wound. Okay.
Yeah.
طيب 70-year-old this is vital stable تمام. يعني إذا كانت طبعا deep wound يعني لسه bleeding we should apply pressure. Okay. And check the eyes. The rejection exam is normal. Apply pressure and we should make a proper dressing. We can give tetanus maybe.
يعني assess what you are going to assess. Assess إذا كان في يحتاج any suturing طبعا
stitches
صح؟
يعني.
Yeah,
أيوة.
and it is superficial mainly it will not need. We may use something that is available in most of our clinics but we don't know about it. مثل شنو دكتور تعرف اللي ممكن يستخدمونه؟
في مثل cosmetics sutures تقريبا هي بس بتقرب الجلد على الجلد.
ستيري ستريبس. صح؟
هي الكوزمت ما بعرف بس
حق superficial scars usually it works very well with those patients.
yeah.
Okay. If I tell you, I want you to, يعني I told you the neurological examination was normal, the vital signs were okay. If I want you to ask the patient one question in this scenario, he didn't get any dizziness. He was tripped by the carpet. So what will be the question?
About his يعني physical symptoms يعني.
Yeah.
Of course, we should ask about something, the cause of the dizziness. Maybe he had dizziness, then tripped by the carpet. Maybe ask about vertigo signs. Maybe we should ask about the sugar, maybe hypoglycemia, maybe hypotensive at the time of the fall. We should observe him for 6 hours at least. Maybe some bleeding comes in the head, like dural hemorrhage, which is common in old age. Does not have symptoms at the time of injury. So he should be observed at least for the.
What are the symptoms, doctor, that you are going to ask the patient about?
Projectile vomiting, any unilateral numbness or weakness.
Okay.
Yes, you should ask him about any dysarthria or dysphasia.
بعد دكتور شنو ممكن نسأل؟ شنو الأشياء اللي that makes us more toward referring the patient for a CT scan?
Any change in the
neurological deficit is one of them. Also, what else?
Headache.
Okay.
Severe headache, thunderclap headache.
Okay. بعد.
Nausea.
Okay. Loss of consciousness, Dr. Shrike, after the fall.
Yes. Any change in the. Because I see the neurologic is normal, so of course he should be have Glasgow scale 15.
Neurological examination, but we never know what happened after the fall. Yeah, right away after the fall, maybe he lost consciousness, then he regained consciousness and came to us conscious. صح?
Yes, of course. Yes.
Yeah. ممكن لأن scar is around the eye or the wound is around the eye. Maybe we should ask about vision. If he's looking clearly, there's any visual abnormality. صح؟
Of course.
شنو الساينز اللي حتى ممكن نشوفها which indicates there is a hematoma?
Yes, dilated pupil on one side of the eye, unilateral dilated pupil. And sometimes if he is seeing halos.
Okay, يعني visual abnormalities.
Yes, visual disturbances, halos.
رايك دكتور بالباند eye?
Yes, basal skull fracture,
yes.
raccoon eye, and nasal bleeding, nasal discharge from the CSF.
Exactly. ممتاز. طيب في هالحالة هذا المريض قلت you want to observe this patient. شلون راح يعني تلم الحين جايك هذا المريض صاحي وزين he's fine, he's doing well, his vital signs are okay. There was no dizziness, no loss of consciousness, no vomiting, no amnesia, nothing, no like hematomas around his eyes, no CSF leakage, neuro exam was normal. شنو راح تسوي له؟ شنو تحتاج تعالج extra things that may help you in like further management? After يعني وسويت له حطيت له strips he's fine now. He's in front of you doing well, he's fine talking to you. شنو شيء ممكن نسوي؟
ممكن نطلب يعني من الاهل observation 24 hours اذا كان جاي مع
تمام
24 hours.
ممتاز.
نسأل إذا في caregiver, who's the caregiver and the medications he's on.
أيوة medications. ليش؟ شنو ممكن يكون المedications دكتورة؟
Some of the hypertensive medications will cause for heart block or syncope.
اوكي يعني انت افتراضا انه يكون السبب الطيحه كان انه صار عنده سينكوبي. اوكي بعد شنو شيء مهم؟ مانجمنت affects المانجمنت لان احنا الحين الكوز we are happy and we are comfortable that there was no, it wasn't a dizziness. He just tripped from the carpet. But it wasn't a dizziness, it wasn't something. فشنو medication, we should keep in mind, in a 70-year-old gentleman, maybe he has comorbidities, I don't know, we don't know the past medical history. And then that will affect our management.
He has bleeding disorder or he is an
Bleeding
anticoagulant.
Very much.
There's tendency to have bleeding, yeah, or hemorrhage.
Is on any anticoagulation, or he has any anticoagulant, the coagulation problems. Yes, thank you very much. Thank you all of you for your participation in this scenario. دكتور ودكاترتنا مشكورين. Okay, so we will talk about, as it is very obvious, about accidents or like traumas, whether due to road traffic accidents, fall from height, fractures, head trauma. All of these are traumas, or all of these are like events that we may encounter in the clinic. So whenever we are seeing a patient, we have to take brief history. Of course, if this person is like in pain or it's bleeding or like dizzy or having any symptoms, we will not have time to take proper history, but we will try as much as possible to take brief history of what happened exactly. Whenever there is a fall, there is a trauma, there is a fracture, we have to ask about the nature of the event or the trauma, how it happened, when it happened, what was there, the story. If there's any witness, we can take history from the witness, the caregiver or a family member or any like witness like brought the patient to the clinic. So also we have to assess, is the patient presenting to us stable or unstable by checking vital signs, the ABCDE, the Glasgow Coma Scale to look for the conscious level. We have to assess if there's like neck trauma. We have to stabilize the neck by a neck collar. Signs and examination findings should be assessed. We have to approach, then we will go to like managing this patient fast as this is an emergency. So we have to think, is what we need to do is life-saving, or we have to save a limb, for example, or we have to save the spine by a neck collar or stabilizing the patient and not moving the patient. So all of these should be considered. For example, limb saving, for example, a patient came with like he had cut his finger, for example, we can keep the finger in ice, for example, to save the limb and stop the bleeding and give IV fluids. If there is a neck trauma or an accident that like we may suspect a head trauma or a neck trauma, we can put the neck collar. So we have to think how we will save the affected area, whether it is the life of the patient, a limb, or a spine. It depends on the situation itself. Medication that may be considered a painkiller, especially if there is like a fracture or there is any like severe pain, fixation and stabilization. We have to consider giving IV fluids, especially if there is bleeding, and we will have 2 large bore cannulas inserted in the patients to make sure that we will replace the fluids that he's losing and trying to stop the bleeding. We have to do dressing for certain wounds and cut wounds. And then we may consider giving tetanus toxoid, especially if the trauma happened in the street or like by an accident or any of the scenarios that the patient may present with an infected wound, or so we will have to give the tetanus toxoid. There are special situations that we should keep in mind. If there is a head trauma, when to refer and who to refer. If there is any bleeding, if there is any medical legal issues about behind the situation of what happened. It was a fight or it was a road traffic accident that needs medical legal issues and legal papers. There is any bleeding, of course, which needs, as we said, intervention and fast intervention with IV fluids and all the other management that needs to make sure that the patient will not have any hemodynamic instability. So when to refer the patient with a head trauma. NICE has strict and clear guidance regarding which adult patients are safe to discharge and which need further CT head imaging. The latter group are also divided into 2 further cohorts, those who require an immediate CT head and those require CT head with 8 hours of injury. I think we have mentioned those with the neurological emergencies. So like just to summarize things, the CT head immediately needed for a Glasgow Coma Scale of less than 13 on initial assessment, or anything below 15 at 2 hours post-injury suspecting open or depressed skull fracture. any of the signs that indicates basal skull fracture like hemotympanum, the panda eyes, or cerebrospinal fluid leakage from the ear or nose, which is called the Battles sign. Post-traumatic seizures, focal neurological deficits, more than 1 episode of vomiting, and also a CT head should be done within 8 hours. And we have mentioned this in the last, previously in the last session, that if we have a patient who is on above 65, having like an dangerous mechanism of injury, having bleeding disorder, on any bleeding, any anticoagulant medications, or having any of the neurological deficit that has been mentioned, we have to refer this patient for CT head. We will not take the 8 hours rule because in general, this patient needs observation. So they will observe this patient in the secondary care, and after 8 hours, maybe they will consider a CT head. And also, I remember that we have mentioned in the last session about head trauma and pediatrics also. So those are, in general, just like a reminder of the head trauma and how we are going to manage such cases. So in case of a trauma, we have to assess the ABCDE and Glasgow Coma Scale. And if conscious oriented, the Glasgow Coma Scale is 15/15 and hemodynamically stable, we may like consider painkillers. If there's a fracture, we have to stabilize and refer to orthopedics emergency. If there's a cut wound, mild bleeding, we have to do dressing, IV fluids, refer to surgical emergency. If the patient is unconscious or Glasgow Coma Scale is less than or equal to 14, unstable, bleeding, or head injury, insert 2 large bore cannulas, start IV fluids, fracture, stabilize, and refer to general hospital where they will consult the orthopedics for the fracture, but they will manage the hemodynamic instability. And also those are the indications as mentioned here for referral for CT head for pediatrics and adults. All of these we have mentioned last slide, right? صح يعني تذكرون? The last session, I mean. Okay. So just to make things more clear, احنا قلنا we are talking about falls from height, fractures, RTA. تكلمنا last session about the fall from height at what meter, how many meters that considered a dangerous a dangerous height, whether for pediatrics or adults, and also it is mentioned here, I think, in those slides. Yes, 1.5 meters height. RTA, it's not very common to encounter a patient with road traffic accident in the primary care settings, but sometimes there are like minor RTAs where the patient had like a minor road traffic accident, or for the doctors that are like working, especially nowadays in the winter season, where some of the children are like taking buggies. If you know this, هذا البuggy اللي يستخدمونه, like it's like a type of motorcycle that like they drive it in the desert, or sometimes even in the area. يعني في صليبيخات أنا كنت وايد أشوف يجونا أطفال طايحين من البuggy. You never know when you may encounter a patient with a traffic accident or even a pedestrian accident. In situation of traffic accidents, whether المريض قاعد يمشي وندعم, whether on a cycle, الحين وايد نشوف مساكين اللي يوصلون طلبات وكرج وهذول اللي على السياكل, وايد نشوفهم يطيحون. أنا مرة شفت على الدوار واحد مسكين طايح بالأرض. We are seeing some such patients. So just make sure to stabilize the neck, make sure that you will not move any limb that is like affected, stabilize the limb if you can. Otherwise, just like keep it and ask the patient not to move it. Make sure to start IV fluids. Since we don't know if the patient is bleeding, we have to assess vital signs to make sure that the patient is hemodynamically unstable, and follow this scheme to like direct the patient properly on a timely manner. Okay, so scenario number 4, a 16-year-old boy presented due to testicular pain, started 3 hours ago. The pain was so severe and associated with left side scrotal swelling. The patient was afebrile. He has on examination loss of chromosteric reflex, and the left scrotum was swollen. So anyone can participate in this scenario. أهلا. عليكم السلام. تفضل.
The boy is 16 years old, particular pain, acute pain 3 hours a day, severe pain, loss of gastric reflex, and mostly testicular torsion.
Yeah.
So
this is one. يعني we have to just rule it out. يعني even if we are like we are not 100% sure from the diagnosis, we have to rule out or we have to like refer the يعني you will tell me what we will do زين just to rule out testicular torsion. Okay. So what you are going to do?
Call ambulance first to take vital. Then I must refer urgently because this is and he needs urgent surgical intervention.
Yeah. شنو راح يسوون له دكتورة؟ هو راح يقول لك مثلا شنو راح يسوون لي بالحوادث؟ So what do you think? What you are going to tell the patient?
هو المفروض operation يعني إنه
اوكي.
أقول له إيه؟
اي يعني usually لما يروح الحوادث على طول راح ياخذونه يودونه غرفة العمليات. Any investigations will be done, anything will be done, any like if there was no if he refused the surgery, for example, what will be the consequences? The patient has to understand his problem, right? I know it's sometimes يعني where we don't feel so comfortable to discuss such a case with a patient, especially a young adolescent patient, and we are like females, but we have to do what we have to do, صح؟ فشنو what you are going to tell this patient?
يعني كإكزامينيشن دكتورة ولا يعني؟
You examined and you have the suspicion, the high index of suspicion that this is testicular torsion and you want to refer the patient to the emergency. ايش تقولي له؟ شنو بتشرحي له؟ تخيلي تحكي بالعربي. انا عندك المريض موجود وانت قاعد تكلمينه وبتحولينه الحين، فهو قاعد يقول لك شنو دكتورة؟ شنو المشكلة؟ ليش تبي تحوليني؟
لأن في مشكلة بالتستس ويعني لو أنا يعني لو في وقت عدى طويل أو سبتها أو كده ممكن بيحصل مشكلة إن التستس نفسها ممكن يحصل فيها مشكلة يعني مش عارفة بصراحة أقولها إزاي بالعربي دكتور. يعني إنه لازم الحين يروح الطوارئ علشان يعني يردوا التستس بوضعها الطبيعي على أساس ما يصير فيها مثلا ضمور أو مشكلة يعني يعاني منها لما بيكبر.
شنو المشكلة يعني شنو راح يصير؟ Explain it if you cannot say the term in Arabic just explain it. شنو راح يصير؟ هي الحين ملتوية فشنو قاعد يصير في البلاد فيزلز أو البلاد سبلاي؟
decrease البلاد فلو blood supply ممكن يحصل زي اسكيميا يعني اسكيميك
أيوة.
نعم
يعني ما قاعد يوصل لها والمفروض تغذى في الدم والحين الدم ما قاعد يوصل لها فممكن هذا يسوي لك مشاكل في المستقبل. شنو ممكن يصير له يعني this person if not treated on a timely manner شنو ممكن يصير له؟
يعني بعدين infertility يعني infertility this
yes exactly. وشنو الويندو مالت الوقت اللي هو المفروض يكون ليش it's important to know when was the problem started؟
أنا مش عارفة كم اور بالظبط بصراحة.
4 ساعات ونص تقريبا.
exactly.
نفس التي بي اي ولا ايه؟
شنو؟
نفس التي بي اي بتاع الستروك. انا لسه سامعه المعلومه دي امس يعني. نفس الفورن ابورد بتاع التيشو بلازمينوجين اكتيفيتور في الستروك يعني نفس يعني
mainly 4 hours yes and after 12 hours يعني evidence have showed إن خلاص the testicle may be damaged within 4 hours the surgery should be done okay فهو لازم يفهم المريض لازم يفهم إنه he should be referred fast and maybe they will وطبعا من الانفستيجيشنز اللي ممكن يسوون له إياه يسوون له ultrasound حق دوبلر يشوفون البلاد فيزلز on the test يعني على testicles to make sure that يعني to confirm the diagnosis but usually there is no time يعني sometimes the clinical examination and the presentation is sufficient to put the patient to send the patient to the OT okay لأن there will be no time يعني ف they will do it as fast as possible.
دكتور بس في علامة ساين فرين ساين
شو اسمها؟
friend sign if we raise the testicle the pain is relieved.
Yes, exactly. Yes.
I'm sorry, it's not relieved in the torsion, but is relieved in the infection with the dermatitis.
عدل. فهذا الديفرنس between the two.
Friend sign.
هني loss of cremasteric reflex is the sign that we may look for.
Yes.
Yeah. Another thing that we may talk about, طبعا حتى testicular torsion, the patient may present with abdominal pain. So acute abdomen and urological emergencies, the patient may present with abdominal pain. So أهم شيء لما نيجي مريض abdominal pain, we have to know the nature of the pain, the Socrates اللي هما الsite, duration, onset, aggravating and relieving factor, associated symptoms, because all of these may help us to know which organ we are talking about. So we have to know what are the key questions that we have to ask the patient in order to know the organ that is affected and causing this acute abdomen or abdominal pain. So the symptoms, as we said, it will be also abdominal pain, maybe associated with nausea, vomiting, severe pain, radiating to the back, for example. If it is loin pain, radiating to the scrotum or the thigh. So all of these questions and history taking is very important in case of acute abdomen or abdominal pain. So we have to look for any signs, any specific signs in the abdominal pain, like the specific signs for appendicitis, for example, specific signs for acute cholecystitis. So all of these should be the rigid abdomen, for example, if there is any rebound tenderness, any tenderness in general in a specific area, all of these should be assessed. So we have to keep differential diagnosis, and by key questions, we have to think of what is the possible and most probable diagnosis. So approach to the management in a case of acute abdomen or urological emergency, of course, the patient is in pain. So the first thing we will think of is painkillers. In the past, you may find that guidelines will say in acute abdomen, don't give a painkiller because you will mask the pain. So whenever the patient will go to the emergency room and the surgeon there will examine and put his hand on the abdomen of the patient, because of the painkiller that you have given, the pain may be relieved and the signs will be masked. That's why, طبعا, and this is inhumane. هذا أول كانوا يقولون don't give كتب السيرجري كانوا يقولون don't give painkillers. Few years ago, this has been changed because keeping the patient in severe pain is inhumane. But at the same time, we don't want the signs to be missed. فشنو الحل؟ الحل إنه we do proper examination and we write the proper signs that we have seen. And usually mild painkillers that we use in the clinic will not relieve the pain totally if it is severe and acute abdomen. So painkillers may be given in acute abdomen. If the patient can't tolerate the pain and you don't want to mask and you are not sure about the signs, it's fine. You can refer the patient as fast as possible and they will examine him and they start the painkillers. Otherwise, you should not keep the patient in very severe pain and just look at this patient because you don't want to mask the signs. If you find the signs, do it, write it down in the referral letter and write that you have been given a painkiller. So for renal colic, what is the first line treatment for pain is the non-steroidal anti-inflammatory, which will decrease the urethral smooth muscle tone and also may help in the pain. Also more like potent or more stronger painkillers may be given, such as morphine. IV fluids also should be considered, and there are special situations that we should keep in mind whenever there is an abdominal pain. If she's a female, we have to think of and rule out any ovarian cyst, for example, ovarian torsion, any ectopic pregnancy, if the patient is having bleeding. So we have to rule out any gynecological problem or obstetric problem. If the child is a pediatrics, he's in a young age, we have just to make sure that we will do the proper examination and refer the patient in a timely manner. If the patient is an elderly, we should keep in mind some other differential diagnosis and we have to examine the abdomen. Please, never let a patient with abdominal pain who's presenting with pain now to get out of your clinic without doing an abdominal examination. I think هذه fatal mistake بالنسبة لي. إن المريض in pain now. إحنا طبعاً أدري أنا كلنا نشوف الحين خصوصاً in this season a lot of patients with gastroenteritis. بس إنه هو مش he's not in pain. يقول عندي عوار لما أروح حمام مثلاً عزكم الله، أو عندي عوار مغص وراح وكذي. but he's not in pain now. بس يجيني مريض الحين يقول لي أنا متألم عوار بطني، أقول له أعطيه بين كيلر وأحوله أو أسوي whatever، أرد البيت من دون ما أفحص بطنه. I think this is يعني very fatal. Please examine the abdomen of your patient whenever there is an abdominal pain. So again, if a female, pediatrics and elderly, ليش إحنا I mentioned this لأن an elderly, maybe this patient will have distended abdomen. We have to ask about constipation. We have to ask about nausea and vomiting to rule out intestinal obstruction because it may be common in elderly. If there is any trauma to the abdomen, also is one of the things that we should consider. A patient presenting with trauma and abdominal pain, we should rule out any hematomas or like bleeding, internal bleeding. So pitfalls in the management of patients with acute abdomen is saying that we should not give any painkiller. Urological emergencies, examples of urological emergencies like renal colic, testicular torsion, and urinary retention. Of course, in case of urinary retention, the mainstay of treatment to relieve the patient from his pain is to insert a Foley's catheter, but sometimes we don't do it. We will refer the patient to the emergency room where they will do proper assessment investigations, and they will mainly insert a urinary catheter. Time of ischemia after testicular torsion, not more than 6 hours, but we have to, like, if we can do the surgery within 4 hours. That would be great. So the time is up to 6 hours, but 4 hours is, it's a time which we should consider. So I think this is, no, مو the last, before the last. 35-year-old lady presented with right red eye and irritation after scratching her eyes while wearing contact lenses. On examination, the right eye is red and the patient cannot open her eye. I will not discuss this because I think we should move on. So a patient who's 35 on contact lenses presenting with red eye, unilateral red eye, after she scratched her eyes by mistake. And the right eye now is red and she cannot open it because of the pain. So what we are suspecting here, يلا شني بسأل خلاص هونت. Anyone can tell me what is the suspicion, what we are suspecting, like the diagnosis that we should keep in mind.
corneal abrasion.
Corneal abrasion. اوكي شو راح نسوي حق corneal abrasion دكتور؟
الصراحه انا بحوله المستشفى، انا لازم اسوي صبغه ويشوف حجم الابريز نفسه اذا كبير، لان بيعملوا لهم فولو اب بالاو بي دي عنده.
تمام.
عاده بيحطوا صبغه بيشوفوا القياس.
صحيح.
يحطوا
dye, which is an orange dye that will be when you put it in the eye of the patient, and there is an abrasion or a scratch or any like foreign body scratch or abrasion, it will be converted into green. راح يتحول لونها من برتقالي إلى أخضر, from orange to green if there is abrasion, and this will indicate that there is like an abrasion, a scratch, or a foreign body, and accordingly they will manage according to the size and like all the other things that they may consider affection of vision and all of these. Okay, so when we talk about red eye is like it raises like a red flag. So whenever there's a red eye, we should like make sure that we have to rule out red flags and we have to rule out serious conditions. So we should take proper history, asking about vision if it is affected. We have to look for a reactive pupil in the examination. We have to see if there is the patient is feeling a foreign body sensation, or in the history there is like a history of recalling a history of a foreign body entering the eye. I have seen a lot of patients who were like يشتغلون carpenters or they work with iron, and like النشارة اللي هو from the wood or from the iron, it's getting inside the eye because they were not wearing protecting goggles. So they may have like foreign body in their eye. So foreign body sensation or foreign body history, photophobia, corneal opacity, hyphema or hypopian. All of these are those are the photos of hyphema and hypopian. Okay, and in those situations we should refer the patient because those are red flags. The following are indication for emergency referral for ophthalmological evaluation if it is unilateral red eye with pain. Unilateral with pain. If there is nausea and vomiting, angle closure glaucoma should be suspected. If there is يعني red eye مع nausea and vomiting. If there is hyphema or hypopion مثل الصور اللي موجودة. If there is visual defects, angle closure glaucoma, iritis or infectious keratitis. If there is corneal opacity or infiltration that stains with the fluorescein, whether we have a fluorescein and we use it. أنا كان عندي كنت ماخذتهم من مستشفى البحر لما سويت روتيشن وخشيتهم عندي. فكنت I use them صراحة أحطهم حق المريض وأشوف إذا في any abrasion that is obvious. And يعني at the end I refer the patient if there is abrasion. بس إذا كانت العيون is clear and the patient is fine and it was a minor trauma or minor like thing, sometimes I don't refer صراحة. بس if you are in doubt, we don't have the fluorescein. Now I don't have the fluorescein, so usually I have to refer if I'm suspecting an abrasion. So corneal opacity or infiltrate that stains with fluorescein, which indicates infectious keratitis. Severe ocular pain due to scleritis or angle closure glaucoma. So all of these cases should be referred. يعني إذا أنا البريض red eye unilateral مع pain or مع nausea vomiting عنده hyphema أو hypopion and the visual defect and the corneal opacity or infiltration مع الفلوريسين أو عنده severe ocular pain, this patient should be referred to the emergency. Red eye that may be managed by the primary care clinics. If it is a STI, احنا نعالجها. Chalazion we can treat. Blepharitis we can treat. Conjunctivitis or conjunctival subconjunctival hemorrhage, of course we can like manage and reassure the patient and treat and follow up if needed. Conjunctivitis in all its types, bacterial, viral, or allergic, we can treat if it is not so severe. Corneal abrasion, urgent follow-up, if not better, in 24 to 48 hours. هذا according to up-to-date. يعني هذا American guidelines, usually they have in their primary care settings. They have also حتى the slit lamp, they have it, and they can do it. They can do the examination in the clinic. احنا usually إذا corneal abrasion or foreign body is suspected, we will refer this patient. Contact lenses wearers or the people with contact lenses and then they have a problem or red eye, also they are considered to be, we can treat them, but usually we will refer them because we don't have the facilities to treat them and to manage them. Dry eye syndrome, also we can treat in the clinic, and episcleritis we can treat in the clinic. So all of these can be treated in the clinic. Again, those three, since we don't have the proper like facilities, we will refer them usually to the secondary care ophthalmology emergency, which will usually they will cover the eye for certain period of time. They don't cover it for a long time to avoid amblyopia. Sometimes خصوصا في الأطفال وايد تصير. Sometimes they put a lens now. They don't cover the eye, they just insert a lens. وعادة هذا treatment moisturizers. Sometimes they will need antibiotics, especially if the patient is wearing a contact lens or the cause was a contact lens. So I think the last scenario, a mother brought her 2-year-old child who swallowed the floor cleaner detergent. The child was active and playful, but the mother was terrified. So it's clearly that there is an ingestion of a corrosive or a cleaning detergent. So ingestion of medications or corrosives in pediatrics. So the management will depend on the severity of the ingestion. In that, if the patient is asymptomatic with low risk ingestion, no evidence of oral lesions, no dysphagia, no vomiting, no other symptoms, we may observe for several hours to monitor fluid intake and overall status. طبعا احنا again we are not a place for observation. فاحنا في حالتنا we will refer the patient. بس احنا شنو نستفيد من هالمعلومة؟ إنه we know the knowledge, we know the management, so we can reassure the family. For example, نقول لهم الياهل زين، قاعد يلعب، يتحرك، he's playful, he's fine, he doesn't have any vomiting, his vital signs are normal. No evidence of oral problem, no dysphagia, he can swallow. طبعا احنا we will not give him something, but he's not like complaining of pain in the throat or in swallowing his like saliva, for example. Usually this patient will be referred for observation in the secondary care. If remains asymptomatic with normal swallowing and if the suspected substance is known to be of low causticity, like household bleach, low risk of complications, then the patient may be sent home. If the patient is symptomatic or ingestion, a high-risk ingestion, upper endoscopy should be performed in all symptomatic patients, those who have oral burns and those who are known to have ingested a substance with a high risk of esophageal injury. If alkali, ingestion and minimal symptoms, endoscopy if symptoms persist within 24 hours. يعني إحنا بالنسبة لنا يعني أي مريض ingesting something, a medication, an overdose of medication, or ingesting a corrosive, ingesting like any abnormal material, we have to refer the patient. بس إحنا راح شو نقول؟ إذا كان he's like fine, he's stable, there is no problem, we will refer him, and they will observe him in the secondary care for a few hours, or we can we will send this patient يعني by ambulance if the patient is symptomatic. Usually they will do endoscopy for this patient in a timely manner. All symptomatic patient, treatment with a proton pump inhibitor for approximately 1 week is recommended. Okay. So the following strategy should not be used. So حطوا في بالكم should not. Okay. ما راح نستخدم هالأشياء. Induction of vomit or is contraindicated. So ما راح نقول حق مريض رجع ولا راح نخليه يرجع نفسه, because vomiting may lead to additional esophageal injury if gastric content comes in contact with the esophageal mucosa. So ما في induction of vomiting. Neutralizing agents should not be used because of concern about additional damage from heat injury during the neutralization process. Diluting agents like milk or water should not be given because of safety consideration and lack of efficacy. The safety concern is that ingestion of a large volume of diluting agent can induce vomiting, potentially leading to further complications. In the presence of acute airway swelling and obstruction, diluting agents clearly are contraindicated. In addition, the amount of milk or other fluids that would be necessary to significantly dilute a causatic agent is too large to make such therapy practical. فإذا هذه الأسباب اللي إحنا ما نستخدم فيها diluting agents such as milk or water. أوكي؟ فإحنا بالبيوت دائما يسمعون إذا أحد شرب شيء عطوه حليب أو عطوه ماء يخليه يشرب ماء. It's not indicated and it is better not to be done. وهذا الشيء اللي إحنا ممكن دورنا نسويه بالكلينيك. أول شيء نعلم المريض. ثاني شيء إنه we don't do those things ونمنع إنه هو يسويهم لأنه we will preserve his safety. Activated charcoal generally should not be given to children who have ingested acidic or alkaline corrosives, sodium or potassium hydroxide or hydrochloride or sulfuric acid. This is because charcoal will obstruct the view of the endoscopist, and because these small highly ionized chemicals are poorly absorbed by the charcoal. Okay, فما راح يستفيد المريض شيء ولما يسوون له scope for any reason they will not see anything of the. ما أدري إذا أنتم شايفينه. أنا مرة شفت ياهل كان شارب ماخذ حبوب overdose of medications, لقاهم بالشارع وخذ الحبة وقاعد ياكلهم. الأهل يابوا طبعا ما يدرون الدواء مو مال بيتهم فما يدرون إيش كثر أخذ فعطوه activated charcoal. He was fine, he was okay, بس كان قاعد يشرب شيء لونه أسود يعني استغفر الله disgusting, and he was drinking it مسكين, بس يعني كان قاعد سامع الكلام لأنه خايف من أهله. And that's it. Thank you very much. يلا حياك أي سؤال.
يعطيك العافية دكتورة. سؤال بس سريع لو سمحتي.
تفضل.
بالنسبة لموضوع الريفيرال للبريفنتيف ميديسن عشان الانيمال بايد، يعني نفترض إذا كان إجا البيشنت بيوم فرايداي جمعة اوريدي هن ما بيفتحوا ليوم الأحد، يعني عادي حتى لو أنا كنت شاكك إنه مثلا خلينا نقول البايد كانت ديرتي ويعني في هايلي سسبشن اوف ا رابيد ديزيز يعني.
شو أنت إيش رأيك؟ وين ممكن تحوله؟
انا احاول الامرجنسي، بس هل موجود بالامرجنسي موجود الفاكسينيشن؟
بريفنتيف نحول الانفكشوس ديزيزز هوسبيتال دكتور.
الامراض الساريه.
الامراض الساريه عندهم امرجنسي.
تمام اوكي.
اعتقد الامرجنسي مالهم، اعتقد اذا ماني غلطان هم للحين ما عندهم مستشفى، فكان كل ديبارتمنت بمكان. البالياتيف الاداره مالتهم بالبالياتيف، واعتقد اجنحتهم مكان بالطب هذا العلاج مال الرئوي مال التي بي وكذي، واعتقد الامرجنسي بالطب الاسلامي مالهم. فتحوله حق الامرجنسي infectious diseases hospital emergency.
تمام.
اوكي.
سمعت يا دكتورة يعني ايه inhalational burn يعني بيحصل ازاي؟
يعني inhalational burn يعني في مثلا burn صار وصار في inhalation شلون يعني انا عندي مريض مره اقول لك مثال. عندي مره مريض كان قاعد طبعا قاعد يطبخ رايح شاليه او شيء ففتح الفرن والفرن طلع كذي كان مفتوح ما ادري شنو صار بالضبط نسيت القصه بالضبط بس شنو انه طلع له هواء كذي فجاه فالهواء عند وجهه فهي انهيلد ذا فليم وحواجبه كلها راحت ورموشه راحت وعيونه تاثرت وصار عنده inhalation burn فهذا كان يعني this is a type of inhalation burn. ممكن هم inhalation burn certain substances highly volatile يعني مثل الميثانول مثلا كان بي inhaled فيسوي burn يعني inhalational burn وtoxicity. فهذه الانواع اللي انا اعرفهم من الانهيليشنال بيرن.
بالنسبة للهاند بيرن هو أي هاند بيرن بنحوله معلش يمكن ما سمعتش حضرتك يعني هو أي ولا حسب السايز؟
According to guidelines, yes. If it is in the hand, it's a higher risk of infection. فيو may consider antibiotics, for example. بس مو أي hand يعني إذا it is superficial burn on the hand, we will not refer this patient صراحة.
تمام. آخر سؤال دكتورة معلش لو بيجي لنا أولد إيدج عندهم أي لاشز في الأي كده ده المفروض أنا بيبقى أحيانا متشاف وأحيانا لأ يعني ده المفروض أنا يعني أعرف يعني المفروض إن أنا أحاول أشيله ولا أحوله ولا
لا don't try to move it تحولينها يسوون لها إياه بالإمرجنسي روم أو حتى مرات مو بالإمرجنسي يسوون لها إياه يعني أنا أذكر مرة بالأو بي دي جتنا مريضة وسوينا لها كان يصير عندها recurrent يعني. فبالنسبة حق الانهيليشنال بيرن أي سموك أي هيت أي كيميكال إيريتنت ينشم يدخل داخل الانهيليشن بالحلق أو بالأنف هذا يعتبر انهيليشنال بيرن. أوكي فهيت سموك فليم كيميكال إيريتنتس كلهم يسوون لنا انهيليشنال بيرن. في أحد عنده سؤال؟ أعتقد ما في أسئلة. Alexandra?
Seems like no more questions.
Yeah.
So thank you so much, Dr. Sara.
Thank
you for your contribution. I think we all agree that
على خير and
we learned a lot from you and the sessions were amazing. And we should be now confident in dealing with emergencies.
Inshallah, hopefully, inshallah.
We wish you all the best, Doctora, and hoping to have you with us as a speaker again in the future.
Inshallah. مع السلامة.
Thank you so much. And good night.
Good night.